So I think we're ready to turn now to launch our conference. So what we thought we would do, our planning committee reflected on how we would like to set the stage, if you will, for our discussion on COVID-19 pandemic and what is happening in terms of changing diagnosis paradigms, as you just talked about there briefly, Daniel. And we were struck that one of the places where this new diagnosis for a new condition was unfolding was on the pages of our leading medical journals. And with that in mind, we thought to reach out to Dr. Eric Rubin, who is the editor-in-chief of the New England Journal of Medicine and also a specialist in infectious disease at the Brigham and Women's Hospital, to provide a keynote that would help us to frame from the perspective that he had in a very unique role of seeing new information coming in about this diagnosis and the sorts of questions that a well-informed editor would have about the role of a medical journal in informing all of us about this new diagnosis. I should say that Dr. Rubin's very impressive biography is available in the materials associated with this meeting, so I won't go into all that. That will be true for all of our speakers today. So with that, I turn to Dr. Rubin, and thank you very much for providing us with this opening set of comments.
Thanks, Andy. And Andy, when we spoke earlier, asked before we get to how you diagnose something, how do you know that there's an outbreak at all? And I think that's something that we've thought about a lot at the journal over the years. If we can go to the next slide, please. And because we, and sorry about the dog, be quiet, dog. Because we think that journals do have an important role, along with other outlets, in communicating about what's going on during an outbreak. And so I'm an infectious disease physician, where do I turn to figure out where these are going on? Next slide, please. One of the good sources for this is an email server called ProMed, which posts, as you can see on the map below, where an outbreak of something that might be interesting or might be important is occurring at the time. Now, there are a huge number of pins, as you see in this map, and they cover all sorts of things. If you go to the next slide, please. You can see that there's currently an outbreak of Lassa fever going on in Nigeria. Next slide, please. An outbreak of an unusual serotype of avian influenza occurring in humans in China, something which occurs pretty much annually. Next slide, please. There are infections not only of animals, but of plants, in this case, the crop teff, which is the major grain used in Ethiopia, for which there's been an infection that has really done a job on the food supply in Ethiopia. Next slide, please. And then there are things that we just don't know. For example, this set of recent deaths in dozens of people in South Sudan, likely due to malaria, but we don't know yet. And so there's an ongoing investigation that the WHO is pursuing in Sudan to try to figure out what's going on. So when you get down to it, there are an overwhelming number of outbreaks going on simultaneously all over the world, both in humans and in animals and even in plants. And so how do we sort those out? Next slide, please. Well, I think we're not always very good at it. If you go to the next slide, here's an example where we got it right. This is a paper published in 2009. It comes from Yap Island in Micronesia, which is near Indonesia and Papua New Guinea. And there was an outbreak of a virus that pretty much no one had heard of at the time, Zika virus, which had been first identified in primates in Uganda. In fact, this did eventually turn out, as most of you know, to be an epidemic that traveled across to the New World and caused a huge number of infections and birth defects. Next slide, please. On the other hand, this is another infection which occurred in 3 elderly German men who were squirrel fanciers, and they kept squirrels, and unfortunately, it appears that they may have kissed the squirrels on the lips. They developed this fatal encephalitis, which turned out to be caused by a Bornavirus. It came, next slide, from these, next slide, please, from these variegated squirrels, which are very pretty, but do carry this virus. But I don't think there's going to be a huge outbreak of squirrel Bornavirus in the world. So that one is an interesting one, but not what's going to come next. Now, if we look back, the pace of diagnosis really helps us understand whether we're in an outbreak or not. As you know, the first cases of pneumocystis pneumonia that occurred in HIV occurred in the early 1980s, were recognized in the early 1980s. But the next slide, please. But the virus that was causing these, HIV, was not identified for another at least year and a half. And because it was such a big deal at the time, it ended up winning the Nobel Prize. So diagnosing a single virus won the Nobel Prize. Likewise, next slide, non-A, non-B hepatitis had been around for years and years and years before a combination of investigators identified and eventually cultured the virus that caused it, leading to the therapeutics that are so effective against it right now. But things have changed. Next slide, please. An example of that is an outbreak of a severe pneumonia that occurred in 1993 in the American Southwest. It was pretty rapidly, when investigated by the CDC, it became pretty rapidly clear that deer mice, the Paramiscus mouse pictured here, was a vector of it. And collecting these mice enabled them to, within several weeks actually, identify the virus. Next slide, please. They could culture the virus and show by PCR that this was a hantavirus, which now goes by the name of Cinnombre virus. So a relatively new pathogen was identified in a matter of weeks. Next slide, please. That was probably matched during the COVID-19 epidemic, and the communication of that was very rapid too. The publications describing the sequence of the virus from both our journal and from the Lancet came out about a week after that sequence became public. Next slide, please. But we still have challenges that we'll be discussing today. Next slide, please. The ones that strike us, of course, are the availability of diagnostics, which has been a problem in all countries from the beginning, particularly in the US, where we really didn't have good infrastructure and is resurfacing now with the use of rapid diagnostics. Next slide. The performance characteristics, which really matter in how we use these tests and really matter for the individual tests that we use. Next slide, please. The equitable distribution of diagnosis so that people in particularly vulnerable settings can be diagnosed, as well as people who are better resourced. And next slide, please. And of course, all the issues with home testing, which were raised in discussions that we've already heard in the introduction, is how do we incorporate home testing as an algorithm into diagnosis? These are things we are very interested in, and I'm very much interested in hearing what people have to say. So next slide, please, which I think is my last. So thanks. Happy to take any questions.
Well, thank you so much, Dr. Rubin, for setting the stage for us about how COVID is among a family of new discoveries of infectious diseases happening all the time. Obviously, COVID has become quite significant in human society around the world. I'm wondering if you have any personal recollections of sort of when you sort of became aware of it and how your own thinking evolved related to, oh, this is going to be a big deal. Was it sort of the equivalent of making a diagnosis in the sense of a patient and seeing that, or did your knowledge of it kind of unfurl more like an onion over time and our understanding of it? I'm curious whether the medical editor's desk, kind of sees the hot story at the moment.
Well, it's a really good question. I think I can't say that we knew what kind of epidemic it was going to be, but we were very concerned about it in December when the first reports came out of China, and we actually contacted some of the some of the researchers there by the beginning of January, asking them if they could report something about what was going on. It did certainly look very concerning. Now, as I said, I'm an infectious disease physician, and we're sort of doomsayers. So this wasn't the first epidemic that we'd seen and thought, wow, this could be the big one. I'm not sure that we realized it was the big one, but it certainly turned out to be.
Yeah. And, one of the things I guess, many of us learned about this condition through journals like the New England Journal of Medicine. I'm wondering, as this has unfurled, how you've kind of thought about the role of your journal in support of improving diagnosis for this condition. Are there key things that you're looking to communicate? I know when we had a chance to chat earlier, you sort of pointed out that there's a role for journalism, there's a role for medical journals, but speak a little bit about what you're trying to think about as the editor at the New England Journal about the role of a journal like yours in supporting diagnostic excellence as it relates to a new condition like COVID.
So I think it is a challenge, and it's a challenge for a couple of reasons. One is timeliness, is that we are very careful about what we publish. We're very careful to try to get the message right, and that takes time. That takes peer review time and editorial time, and we edit, we change every word, or at least every sentence in the article before it gets published, and that takes a while, and things end up in public oftentimes before we before we have an opportunity to get it out there, and yet we think we've curated it to the point where it's useful. Our journal, we're a clinical journal, and we think that our audience, we hope that our audience is both researchers and doctors trying to care for patients, and so we are trying to translate research findings to something that is clinically applicable. And that's particularly true in the days of COVID, when we really want to reduce something to practice. When it comes to diagnostics, that means that we're perhaps a little less interested in the science behind them. And there are plenty of outlets that are certainly interested in rigorously evaluating the science behind diagnostics. But although we are interested, and we have published on several new diagnostics, but we're really interested in that reduction to practice. How would a new diagnostic change things? So we don't publish every diagnostic to come along, but we're very interested in the diagnostic that either is technically or because of its application able to change our paradigm of diagnosis.
Yep, that makes a lot of sense. One of the things that was touched on in the comments just before your presentation was how one of the themes that we'll be touching on at this meeting is how COVID may be playing a role in shifting, where diagnosis occurs from being perhaps a physician-centric activity to one in which the patient is more in the center of it, with things like home testing and so forth. I guess, first of all, do you agree from your vantage point that is going on? And if so, does that influence at all how you think about, as an editor, the roles that a medical journal needs to play in supporting that evolution?
So once again, this is something that we're thinking about a lot. So first, as a physician, and I'm sure that every physician here has the same experience, the questions that come from patients, from friends, from relatives, constantly about testing make it clear that home testing is an integral part, maybe the most important part of diagnosis right now. And that does change the paradigm a lot. From a research standpoint, it means that we are not seeing a lot of the diagnosed cases of COVID. So when epidemiologists try to evaluate how much disease is out there, and if they rely on centrally reported, largely PCR testing, they're only getting the tip of the iceberg. So that's one problem. But the other problem, of course, is for a practitioner, how do you act on information that a patient collected that you never saw, using a test whose performance characteristics can vary quite a bit depending on who the manufacturer is and how well the patient administered the testing. So I think we need a lot more guidance on how to use these. I do want to separate, though, the idea of guidance as provided by an organization like the CDC, which has to act constantly on incomplete information, and the kind of guidance that we can provide as a research publication, where we want a data-based decisions. So I think in a rapidly changing world, we all have to make concessions and maybe not publish what we would ordinarily publish. We've done that repeatedly throughout the epidemic because we want to be relevant. We want to be helping people through this. I mean, at the same time, trying to maintain standards that are at least similar to what we would provide otherwise.
Yeah, I can hear that it's a real fine balance. I mean, as you were speaking, a question came in from the audience that sort of speaks to, and I'm curious whether you would perceive that you have evidence to address it. So the question is, how soon after symptoms begin would you recommend home testing? And I think I hear from your previous comment that, well, the CDC should put out guidance on that. But, does the New England Journal of Medicine provide an evidence base to support that, to allow the CDC or others to make those kind of recommendations, as an example?
So I think the answer is both, that we have published already pieces using both PCR and using antigen testing of various kinds to look at the kinetics of the virus over time, which would help address this question. We also have, just published a piece on the sort of help for a physician. What should we recommend? Which is a little less research-based and much more practical. Knowing what we know today, here's what we do today. Now, as a journal, who considers themselves to be a journal of record, it is unusual for us to be publishing this information, which is evanescent. I mean, it's going to be wrong soon. And we're well aware of the timeliness of what we publish. Nevertheless, we're trying to help our readers deal with these sorts of questions.
Yep, no, that makes good sense. From another audience member, we're hearing, and again, these are just examples, I think, of the kinds of questions that are coming up. And I'm curious, again, whether you think they fit within the context of a researcher. To what degree does having COVID in a patient's history change pretest probabilities in the future? And how do we deal with many situations where COVID may not be in a patient history, like you're describing, where the home antigen test is done and the information is not fed back? I guess it raises questions about as we empower and move the diagnostic process into the home, we're going to need to think about how to support that through the health system. And I'm curious whether you're seeing those kinds of questions raised in the journal, and whether there's going to be a role for research to help us answer these things.
I think that the home testing questions that you're bringing up, Andy, are relatively new ones, and it's something that we have to come to grips with, because there's the research around that is limited. In particular, this question about patients who have a prior history of COVID is a diagnostic question on top of a diagnostic question, because our ability to diagnose previous COVID has been kind of restricted. Early on, there were people doing serosurveys in the community, and the tests that they were using were just okay. They may tell you something about a population. They didn't really help you understand what to do in an individual patient. And so we rely on testing reports from of various reliability, history of various reliability, to figure out who was previously infected and who wasn't. On top of that, as you know, tests can remain positive for a long time, particularly PCR tests in some individuals. Did that person have a second case of COVID, or is it really just the same thing that's been going on? That being said, I think that we've recently published a lot more about patients who had a history of COVID, and using much more reliable sorts of testing or record keeping than we had before. So I think we will know the answers to some of these. Clearly, people who have COVID can get it again, but they are at reduced risk, somewhere on the order of someone who'd been vaccinated. But exactly where, we're just getting the numbers for that right now.
Yeah. You talked earlier, Eric, about, the role of the New England Journal as a research journal of record and so forth. But I do perceive as a reader of the journal that you have made some changes, and I wonder how you think about it. In a sense, there's been kind of a democratization of medical information. And in his early comments, Daniel, pointed out, patients coming to the emergency room, talking to him about pre-test probabilities, probably not something that we would have thought the general public was ready to ask questions about. So clearly, an education is underway with the public. I'm wondering if you could speak to, what your perceptions are of how organized medicine in general and, New England Journal in particular is, trying to think through whether its role and how it disseminates information, the speed at which information is put out, has to evolve to be able to be relevant and meaningful at the time in which we are sort of in the midst of the battle, if you will, with this pandemic. So I'm curious how you've all thought about that at the editorial team.
Absolutely. There's a tremendous tension between timeliness and quality. We are very aware, and we're in a place right now with COVID that we've never been in before, particularly because the mainstream media, the popular press, all covers COVID. They cover it incredibly well. The quality, of course, varies, but many outlets are doing a very good job. And we don't want to compete with the New York Times. The New York Times, the Washington Post, they can disseminate material much faster than we can. So I think our niche is to be very careful with what we present. It is still true that in this time of COVID, when we get a research manuscript, we edit it heavily, including often changing the conclusions, or softening the conclusions, because a lot of investigators, of course, are strong believers in what they work on. So I think we still have a role there, but we have to do it fast. Otherwise, it's meaningless. So we're a little betwixt and between right now. We're trying our best, I'd say.
Yeah. It seems like you've made greater use of some preprints and so forth. And have you had a sense of how that has changed the messaging in a way during the pandemic? Have those things become synonymous with things that are ultimately, printed in the journal and sped things up? Is that part of your process?
Yeah, so I'm a basic scientist who publishes on preprint servers, has for years, and I think they're overall a good thing, but they're overwhelming right now. So part of our job is to curate what's out there. I would say that if you compare a preprint with what we publish, it's usually fairly different, because it's gone through a process of peer review, of editing, of changing the voice and the communications in a way that make it very accessible. But having said that, preprints are a way of getting things out there quickly, and I think they are an important part of the communications ecosystem. Understanding how to interpret those and how to sort through the tens of thousands of articles, I think, remains a challenge.
Yep. Yep. I just want to turn in our just last minute or two here. You touched on an important theme that we will also get into more at today's workshop, and that is the issue related to equity and access. COVID has certainly shined a light on that. I'm wondering if you have a thought at all about, again, sort of the role and responsibilities of organized medicine and, great institutions like the New England Journal of Medicine, which is such a guiding voice for the field, to really take this issue head on. In what ways that you've thought about that a journal like the New England Journal can play in ensuring that this component of quality, equity, is fundamental and addressed in the work that we do related to COVID.
Let me give you two examples or two areas where I think that that's true. One is in research. It is incredibly important that when we do studies, that the populations we study are representative of the populations who have disease. In the case of COVID, disease incidence is inequitably distributed across populations. So it's very important that we bring those populations into our research. And we have advocated for that. In fact, we instituted a new policy where researchers have to be very transparent about how, this is true across all diseases, about how their study population represents the population affected by that disease. So that's one area. But the other area is policy. We see it playing out over and over again in accessibility, particularly. Who can get those home tests right now? Right now, it's whoever can get to Walmart fastest, which is probably not the best distribution system. Right now, the therapeutics for COVID, the one antibody that still works, the two oral drugs that are present in very short supply, should be going to people in the highest risk groups, people in the most vulnerable groups. And yet we don't really have a system to do that. So I think we really need to think through our policies, and we'd like to be part of the advocacy for those policies that introduce equity.
Terrific. Well, Eric, thank you so much for your time and comments. You've kicked us off in a terrific way for today's workshop. Please, everyone, join me in expressing your gratitude for Dr. Rubin and ongoing work at the New England Journal of Medicine. Thank you so much.
Thanks, Andy.